Hello everyone, welcome to another video. So in today's video we'll be talking about polycystic ovarian syndrome, which is also known as PCOS. And this polycystic ovarian syndrome, it is basically a complex hormonal and metabolic disorder, and it usually affects women of reproductive age. So it is majorly characterized by chronic anovulation. Anovulation is like periods where is when a woman doesn't have any ovulation, so she doesn't release any egg. So it's when she does not ovulate, so we know we this is known as anovulation. So it's characterized by chronic anovulation, hyperandrogenism, and polycystic ovaries. So these are the three main common features that we see in this condition, although not all women will experience all these three features. And this polycystic ovarian syndrome, it is the leading cause of female infertility, and it also poses risks of metabolic syndrome, type 2 diabetes mellitus, cardiovascular disease, and also endometrial cancer. So let's look at the background and the pathophysiology. So polycystic ovarian syndrome basically involves dysregulation of the hypothalamic pituitary ovarian axis. So the hypothalamus, it secretes gonadotropin, that the gonadotropin releasing hormone, and this hormone stimulates the pituitary gland to release luteinizing hormone and follicle stimulating hormone. So in cases of polycystic ovarian syndrome, there is an increased luteinizing hormone compared to the follicle stimulating hormone ratio. So this usually stimulates the ovaries to produce excess androgens. That is, androgens are male hormones, so that is why in this case we always have hyperandrogenism. So because of the imbalance in the luteinizing hormone to the follicle stimulating hormone, then it leads to the ovaries producing excess androgens. And androgens, they basically inhibit follicular development, leading to anovulation, that is no egg release, and leading to multiple small immature follicles seen as cysts when viewed on ultrasound. So many patients, they also exhibit insulin resistance, contributing to elevated insulin levels, which further stimulates androgen production and also worsens the hormonal imbalance. So together with this condition, you could also experience type 2 diabetes. So let's look at the risk factors. So the risk factors, basically, number one, genetics. So having a family history of this polycystic ovarian syndrome is a risk factor. Then obesity too. Obesity can generally worsen insulin resistance. Then also having a sedentary lifestyle too, like most of the time you're always sitting, you don't even try to stretch your legs or anything. Even if it's office work, like you don't even, when you have time off or when after work, you don't even try to get your body moving and all that. So having a sedentary lifestyle too is a risk factor. And also early puberty is also another risk factor, and having high stress and a poor diet too. So looking at the signs and symptoms, patients may present with reproductive signs, like they may present with different signs and symptoms. So looking at the reproductive signs, like they will have irregular menstrual cycles, which is known as oligomenorrhea or amenorrhea. And then, like I said before, they will have anovulation and infertility, and then miscarriages too is also a sign that can be seen. Then androgenic symptoms that the patient will experience: excess hair growth, known as hirsutism, on the face, chest, abdomen. So basically all those places where in males you see them having hair. So the person will start experiencing excess hair growth in all these areas. And then acne too, having acne, oily skin, hair thinning, or just having this male pattern of baldness. So these are the androgenic symptoms that could occur due to increase in the male hormones. Then metabolic signs that could occur, for example, weight gain, especially abdominal weight gain, insulin resistance or impaired glucose tolerance. Then also there's something called acanthosis nigricans, and this is basically having dark velvety patches on the skin, often on the neck, around the neck. Then so we've looked at androgenic symptoms, we've looked at reproductive signs, so we've also looked at metabolic signs. So also psychological signs, like it can cause depression, anxiety, low self-esteem, and sometimes somebody can even have body image issues because of this condition. So looking at the diagnosis, diagnosis is made using clinical history, physical examination, and supportive investigations. So there is something called the Rotterdam criteria, and is often used, which require two of the following three indications. So number one, it requires the person having irregular or absent ovulation. Number two, having clinical or biochemical signs of elevated androgens. And number three, having polycystic ovaries on the ultrasound, that is greater than or equals to 12 small follicles per ovary, or enlarged ovarian volume. So the Rotterdam criteria is often used, and these are the criteria that is used. So either two out of these three criteria is used. So additional tests that may show signs of this polycystic ovarian syndrome, like luteinizing hormone and follicle stimulating hormone levels, because like I said before, it's this condition, in this condition, is usually like the ratio is imbalanced between these two hormones. So also thyroid function test to rule out hypothyroidism, prolactin level can also be checked, and pelvic ultrasound can be done too, to visualize the ovaries. Yes, so looking at the differential diagnosis, that is conditions that could mirror this condition known as polycystic ovarian syndrome. Looking at the differential diagnosis, other conditions that could mirror this condition, we have, for example, androgen secreting tumors, Cushing syndrome, whereby we see all these features of exhibiting male hormones. Then premature ovarian failure, hypothyroidism, congenital adrenal hyperplasia, and also hyperprolactinemia too. So these are all the conditions that could mirror the same symptoms like we see in PCOS. So looking at the etiology, or what exactly causes this polycystic ovarian syndrome. So polycystic ovarian syndrome, it is a multifactorial condition, and this means that it has several factors that contribute to the development. It doesn't just have, okay, this one particular thing is causing PCOS. It has several factors. So we're going to break it down and look at like the different, what could possibly lead to this condition. So number one, genetic factors. So like I said before when I was talking about the risk factors, if you have someone that if you have women in your family that have had this condition, like if they are really a lot, there's a more likely chance of you having it too. So if it tends to run in the family, so there's a more likely chance of you having it. And also certain gene mutations may also increase the risk of having this PCOS. Then number two, insulin resistance. So insulin resistance is a major trigger. So many women with PCOS have insulin resistance, causing the body to produce more insulin. So excess insulin stimulates the ovaries to produce more androgens, which disrupt ovulation. So also hormone imbalance. So having high levels of androgens like testosterone and having increased luteinizing hormone relative to follicle stimulating hormone, and also having low levels of sex hormone binding globulin, which increases free testosterone. There are also lifestyle and environmental factors too. Having a poor diet, sedentary lifestyle, stress, obesity, they can worsen insulin resistance, and this insulin causes the production of more androgens, so, and leads to hormonal imbalance. So that is basically it. So in the pathophysiology, so the insulin resistance will lead to hyperinsulinemia, and the body cells don't respond properly to insulin, so the pancreas produces more insulin to compensate. Then these high levels of insulin increase androgen production by the ovaries. So these excess androgens, they disrupt the normal growth and the release of eggs from the ovaries. This will now lead to anovulation, and anovulation is basically no ovulation, leading to irregular periods or absent periods. So the follicles in the ovaries, they begin to grow, but they don't mature properly. So this will cause ovarian dysfunction, and they will form like this small cyst that is seen on the ultrasound. So these cysts, they are actually immature follicles that failed to ovulate. So increase in luteinizing hormone and decrease in follicle stimulating hormone, they cause improper stimulation of the follicles, and more androgen production and impaired estrogen levels leads to worse ovulatory dysfunction. So other systemic effects that could happen is weight gain, acne, excess hair, infertility. So long-term risks can include type 2 diabetes, cardiovascular disease, and also endometrial cancer. So basically, looking at the goals of therapy when we're trying to treat this condition. So first, we have 6 goals of therapy here. So first, we have to restore the menstrual regularity, because here we'll have the presence of irregular periods or absent periods. So we're trying to restore treat the hormone imbalance so that there will be proper menstrual periods. So first, we restore the menstrual irregularity. Then we reduce the androgen symptoms like the acne, the excess hair. Then number 3, promote ovulation for fertility. Then number 4, prevent long-term complications like diabetes or cardiovascular issues or endometrial cancer. Then also support weight loss and insulin sensitivity. Then that's the final one, address any emotional or psychological issues that might have arisen due to this condition. Then looking at the treatments, like how we can manage this. So the management depends on the patient goals, whether fertility is desired in the patient or not, and also symptom burden. So first, looking at the lifestyle modifications. So the first line in all patients, especially if overweight or obese, is to try to aim at 5 to 10% weight loss in order to restore the ovulation and to reduce the androgen levels, and also having a balanced diet, and reducing sugar and refined carbohydrates, and also having regular exercise, like at least 30 minutes a day, 5 days a week. Then these are the lifestyle modifications that are very helpful in this condition. Then looking at hormonal regulation, which is non-fertility focused. So combined oral contraceptives can be useful here, like a combination of estrogen and progestin. So they would help regulate menstrual cycles and lower luteinizing hormones, reducing androgen production, improve acne and excess hair, and protect the endometrium from hyperplasia. So an example is ethinyl estradiol combined with cyproterone acetate or levonorgestrel. So this is an example of a combination of estrogen and progestin that we could give for when we're trying to aim at hormonal regulation. So then we also have the approach of giving anti-androgens, so to counter the whole increase in androgens. So is used in the case for the excess hair or the acne in combination with contraceptives. So for example, spironolactone. So spironolactone is an androgen receptor blocker and is a mild diuretic. It's a potassium sparing diuretic, so it's also an androgen receptor blocker, and we can give 50 to 100 milligrams twice daily. And while we're giving this, we have to monitor for the potassium levels in the patient and the renal function. And then something else we can also give is finasteride. Finasteride is a 5-alpha reductase inhibitor. It's usually not first line, so it is used more specifically in resistant cases. And then something we could give to slow the facial hair growth is, there's one particular cream we can give, eflornithine cream. So this cream can help with to slow the facial hair growth. And then when we're looking at ovulation induction, that is when we're looking at the if the aim is to increase fertility. So number one, we can give letrozole. So letrozole is usually first line, and it is basically an aromatase inhibitor which lowers estrogen levels and increases follicle stimulating hormones and leads to ovulation. So we can give like 2.5 to 7.5 milligrams for 5 days starting on day 3 of the cycle. So it usually gives better pregnancy rates. And then another drug we could use in this case is clomiphene citrate. So clomiphene citrate is not first line, like letrozole works better than this clomiphene citrate, but they still do the same job. So clomiphene citrate is a selective estrogen receptor modulator, and increases gonadotropins and ovulation. But with this, there's a higher risk of having multiple pregnancies. So also metformin too is used adjunctively in insulin resistant patients. So it improves ovulation and the metabolic profile. So also giving gonadotropin injections or laparoscopic ovarian draining. So this can be done for resistant cases. Yeah. So we could also give insulin sensitizers even if like our goal is, even if fertility is not our goal, we could give insulin sensitizers, like I said before, metformin, which improves insulin resistance and promotes spontaneous ovulation and also lowers androgen levels. Then psychological support too. So many women with polycystic ovarian syndrome, they suffer from depression, anxiety, and eating disorders. It's a very complicated condition. So giving proper counseling proper support is very essential for any woman going through this condition. And also monitoring the patient and doing follow-ups too is very essential. So doing follow-ups, like if there's to know the menstrual pattern regularity, if that's come back, to get more information about the ovulation signs, if the patient has started ovulating, and also the weight loss progress, and also monitoring for the blood glucose levels, monitoring for the liver and kidney functions based on the medications that is given. So this polycystic ovarian syndrome, it is chronic and it requires long-term treatment. However, symptoms can be controlled with consistent treatment. So many women, they conceive with treatment, and risk of complications can usually be minimized if they follow the appropriate treatment. But some complications can occur if left untreated, like number one, infertility, endometrial hyperplasia or endometrial cancer due to the unopposed estrogen, increased high levels of the estrogen. Then type 2 diabetes mellitus, dyslipidemia, hypertension, cardiovascular disease. So there are just a lot of complications that comes with this condition if not treated properly. And it's basically how do I put it, so we have to provide the proper counseling, and the patient has to try to take their medications as they should, try to help themselves with lifestyle changes, because lifestyle changes can be very beneficial even when you're taking medications. And then monitoring for drug to drug interactions too, and ensuring that the patient does proper contraceptive use if they are not trying to conceive, and also giving support and psychosocial care. So all these things go a long way in this particular condition. So that is all about polycystic ovarian syndrome, and yeah, I'll see you in the next video. Bye.